Hi, hello everybody, and welcome to week 5 of the STAR Center's Workforce Data Metrics Learning Collaborative. Thanks for joining us here at 2 p.m. Eastern for this week's webinar. Just a quick reminder who we are. We're the STAR Center. We're funded under the National Cooperative Agreement with the Association of Clinicians for the Underserved. So we bring all this stuff to you for free, and we've been lucky enough to use that agreement to offer this learning collaborative for the last 5 weeks. Just a quick couple of housekeeping announcements. As usual, we are recording. The recording of this webinar will be shared out via email to you all tomorrow morning, most likely. Fingers crossed if everything goes well. We'll get that out to you. The slides will also be made available for you to review later on your own. We hope that you'll ask questions. As always, we try and save a little bit of time at the end of our half an hour here to answer your questions. If we don't have time to get to that, because this is a short amount of time, we'll either address them individually with you via email, or we'll bring them up next week as we get started. And just one last little bit, have fun. Hope you enjoy your time with us today. Allison Albersikra is out of the office on vacation, enjoying her time this week. So my name is Mariah Blake. I'm here with you today, as is my email address. If you have any questions throughout the session, issues with your technology, sound, any of that, either put it in the chat or shoot me an email there. And we also have our presenter, Paddy DiPadova's email there as well. And I will hand it over to Paddy now so that she can get started.
Great, thanks, Mariah. Can everyone hear me okay? Can you hear me okay, Mariah?
Yep, you sound great.
Great. I'm just trying to, did you give me the?
Yep, if you just click the one, it should give you control, and on your next click, it'll move forward.
Okay, sorry about that. So today's objectives are to use data that you might not normally use in a human resource context, but practice data that's used for practice management purposes is also very critical in terms of identifying the need to recruit, looking at potential issues that might be impacting retention, and planning for vacancies and succession. So when is it time to recruit? There are 3 things that I take a look at in terms of determining whether there are enough providers to take care of the patient population. Capacity compared to demand. When we're looking at capacity, the 3 measures that we look at are panel size, productivity, and appointment access. So panel size, you may not all impanel your providers, but it's really a best practice that patients are paired with a primary care provider and become part of that provider's panel. So the definition is the number of patients that the provider is responsible for based on a full-time equivalency, so an FTE. You can collect that either by the number of patients seen in the last 18 months or the number of medical charts that a provider is responsible for. A lot of health centers have patients choose their primary care provider, and you can run a list, then a report of who is in the panel for the provider. So panel sizes can vary a great deal. Size typically can be between 1,000 and 1,200 patients for an internal medicine provider. And then family practice and pediatrics can be a little bit more. Family practice is a little closer to internal medicine because they're presumably seeing a lot of adults. Pediatrics is usually quite a bit more because they're seeing a lot of children, and those visits are typically shorter because the children have less intense issues and shorter medical history. So there are a lot of things that go into making that visit shorter. Family practitioners also sometimes practice by seeing several people at once in a family. So they might treat 3 children in a family for strep throat at one time. So again, their panel size can be a little bit bigger depending on the number of children involved. If a family practice physician or an internal medicine physician specializes in any way by seeing a high number of HIV patients, for example, or an internist specializes in some other way, then their panel size would be expected to be smaller. So you kind of have to get a feel for the specific practice for that particular provider. Nurse practitioners and PAs can also have panels. I usually recommend that they share a panel with a physician as part of a team, and we'll talk about the team aspect a little bit later on. This chart gives you an idea of how to measure for panel size, and also to take a look at continuity. How often are patients actually able to see the provider that is their primary care provider? Just going to back up. I wanted to point out that the continuity measure from that next chart can also be used as part of patient-centered medical home recognition under AC 11. So just if you're working on patient-centered medical home recognition or renewal, AC 11 could utilize this type of a chart. So productivity is still a predominant measure of patient care. We know that practices are changing, and really less is being driven by visits than in the past. However, visits still are the basic measure of patient care. So taking a look at how productive providers are gives us an idea of how busy they are. We know they're also doing other things through their portal and on the phone and potentially even seeing patients in the hospital. But visit productivity is still a pretty solid measure. It also gives us an idea of financial stability, how patient access, which is our next measure, can be impacted by productivity or lack of productivity, and that there can be significant issues with provider and support staff satisfaction on both the low and high ends of productivity. On the low end, people can get bored, they can be less efficient, and on the high end, clearly there can be great burnout. So this chart is what I would use to measure productivity if you're not measuring it already. A lot of EMRs can easily pull this data for you, but this takes a look at the providers, their type of provider, meaning the degree. So that would be MD, DO, NP, PA, their specialty, their FTE, how many health center visits they have. So panel size is by unique patients. Health center visits is duplicative by patient. So if a patient came in twice, there would be 2 visits. And then with a comparison to the UDS mean, you could take a look at and see how you compare with visits per 1.0 FTE to UDS means from either regions, your state, or nationally. And getting an idea about what your difference is. And there can be lots of explanations for those differences. Again, a provider that sees predominantly HIV patients is going to have lower productivity. So there are lots of ways to take a look at this, but it gives you a rough number to start working with. So once you know productivity, this is just a summary table where you can list each provider out. It's often helpful to give providers this information because they can help provide the reasons for the differences. or they can maybe get really good feedback and see that maybe they're not as productive as other providers and work with them on some type of quality improvement process to improve productivity. So here are some of the possible reasons that someone may have high or low productivity and potential consequences. And these really do impact recruitment and retention, but it's important to know what these are so that when you're looking at the data, you can help inform your recruitment decision. So possible causes of low productivity is a new provider. You know, it's definitely they need some ramp up time, one, to get patients interested in coming to them if they're new, and two, because if they're a young provider, it's going to take them more time to see patients. They're going to be seeing patients that are to them, so they're going to need longer visits to get to know the patients. They also are going to be less experienced, so they're going to need more time to look things up, to consult with other providers. So that's a normal cause of low productivity that you wouldn't expect to last beyond 2 or 3 years. Another way that productivity can be low is if providers are traveling between clinic sites and they're losing time due to that travel. Differences in on-call coverage can make a big difference. If one provider is taking more call, they're not going to see patients as much in the office. Scheduling issues, we'll talk about that a little bit. Staffing can impact low productivity. Inefficient use of space, just a slower pace. You know, providers have different paces that they work at. Low patient demand and excess capacity. And excess capacity and low patient demand are the things you're going to be most concerned about from a recruitment perspective. So the consequences, again, with low productivity, reduced patient access. There can be unfair labor distribution for higher producing providers having to work more, provider boredom or dissatisfaction, reduced revenue, and it's not a great use of resources. High productivity is what, you know, everyone aims for, but we also need to be careful with that. Usually those are experienced providers. They may have extended clinic hours. Again, there could be differences in on-call coverage distribution, scheduling. It could be providers working at a faster pace, high patient demand, and there could be a capacity shortage depending on how high the productivity is. And the worry there is that you have overworked providers by not having enough providers. Again, unfair labor distribution, provider burnout, staff stress, that means support staff as well. And potentially you have a provider vacancy that needs to be filled. So one way to kind of pull these together a little more is to take a look at appointment access. This is my favorite measure because this is the one that shows how patients are being impacted by decisions in the practice. Appointment access gives information on how easily a patient can get in for an appointment, how long they have to wait to get an appointment, not how long you're waiting in the waiting room, but if they call today, how many weeks or days does it take to get an appointment? It's really important for determining recruitment needs because it is matching that demand with capacity. This is another patient-centered medical home measure for NCQA. It's typically you measure it with the third next available appointment, and this falls under PCMH QI03. And you develop policies based on clinical norms. So what would the norm be for how soon someone should be seen for a sick visit, a follow-up visit, a physical, for example? So this looks a little complicated, but it's basically measuring appointment access by individual provider, but also by specialty. So specialty meaning family practice, internal medicine, pediatrics. So that if someone couldn't get in with their own provider, how long would the wait be if they were willing to see a provider within that same specialty? So it's counted in days, and you'll see here there's a days for the provider and a days for the team. So the team would include anyone in that specialty area. And then you would have set a policy for how quickly you think clinically people should be able to get in. Typically a physical might be 4 to 6 weeks. Sick visit, 0 to 1 day. Follow-up within a week of when the provider would like the follow-up appointment. And then the column for meets policy would be just yes or no, and then what the corrective plan is. This is using the third next available appointment, so that if you look at one appointment at 2 o'clock tomorrow, that's the first, and if the next one is next week at 4, that's the second, and then the following one would be the one that you would use. That's to allow for cancellations, changes in the schedule, and to more normalize your measure, so there's not a lot of variability that's unique to a particular day. So again, you take a look at appointment access in terms of analyzing it and including productivity. And adding these two together, we're calling on whether it would be measuring capacity and looking at whether there's a capacity gap. So taking a look again, we looked at the reasons for productivity. Now we're putting together appointment access and productivity and adding in a few situations for low productivity and low access. And in this case, low access means it's a long wait to get into an appointment. So this is someone who's not seeing a lot of people, but the patients have to wait a long time to get in. So it could be, again, a new or slow provider, or the office hours are being used for other activities such as administration, quality improvement, or the office hours are not really reflecting the contracted hours. That is often the case. Or there could be other things not related to the provider, limited exam room space, limited support staff that are slowing the provider down. So for this case, the action would be to identify the reasons for the low access and target it with an action plan and a quality improvement process. If there's low productivity and high appointment access, so this is someone who's not seeing a lot of patients, but it's a very short wait for them to get in, that means there's a low provider demand usually. Again, that's probably a new provider who could benefit from marketing the practice more or working with it in a team that's more established that could help build the practice. It could also be an unpopular provider, and that's important to know. And you may get that from patient satisfaction surveys combined with this kind of information. So the action in this case would be to review low demand causes and again, figure out what types of quality improvement plan you could put in place. In this instance, if you have low productivity and a high appointment access or a short wait for an appointment, you would not think you'd be recruiting for another provider. So if you have high productivity and a long wait to get in for an appointment, you have an efficient provider with high patient demand. So the reasons could be that you're understaffed due to a vacancy or there's just been a big increase in patient demand. Could also be a very popular provider. So if this one provider has this situation, but the rest are kind of low producing providers, then you need to take a look more at that team approach. The action is that you may need more capacity to meet patient demand if all of your providers are in this situation. And that's when you'd really start taking a look at whether or not you need to recruit and take a look at reviewing your team-based care structure. you have a highly productive provider with a short wait for an appointment time, you have a very efficient provider who's meeting patient demand. That's usually a very well-functioning practice with an efficient provider. So one thing you need to be aware of is just checking in with the provider to make sure they're not experiencing stress, that they're not working extra hours to keep that short wait time, and that they're not going to burn out on you, because this is exactly where you want providers to be. So you need to keep tabs on how they're working within the clinical standards. So those were really kind of the things to point towards whether or not you need to recruit a provider. It's also important and critical to keep the providers that you have. We all know that it costs a lot more to recruit someone new due to many different costs than it does to retain the providers that you already have. And so some of the things we're going to talk about are provider mix, adequate support staff, and schedules and space. So care teams and provider mix are really important. It's critical to have interprofessional teams. It's a really strong model that's really, again, part of patient-centered medical home recognition. It promotes provider retention and recruitment due to a collegial environment and people being able to work at the top of their license. And in order to get this kind of mix, it's important to consider non-physician providers for physician vacancies if you do not have many in place already. So this is just an example of taking a look at your ratio of non-physician providers to physicians. These numbers are a little bit old, but it's showing what the UDS national roll-up is in terms of the ratio, and also the Medical Group Management Association mean per physician FTE. So having a reasonable ratio of well-trained support staff as compared to providers is key. It really can ease provider workload and prevent burnout. It improves patient flow, it improves provider efficiency, and it improves both provider and support staff satisfaction. You can also have a high ratio of support staff to providers, and that ends up being an inefficient use of resources, spending money where you don't need to. A low ratio is inadequate support, and that can really cause some problems with provider retention. So this is a chart just to give you an idea of taking a look at measuring different categories of non-provider staff ratios, and then plugging them in and comparing them to UDS data and Medical Group Management Association data to see how you fall. Now there is a range with all of these, so you don't need to be exactly on. But if you're 3 or 4 times higher than both UDS or MGMA in any area, it would be reasonable to assume you may be overstaffed. Or if you're way lower, that you may be understaffed. And it might just be that people's skill sets are being used in other ways, but it's also worth taking a look at in context with all these other measures to see what's going on. So other things that really can drive productivity and access and again, impact retention would be support staff coverage, which we just talked about, but also exam room availability. So the number of exam rooms, the patterns of provider scheduling to use those exam rooms, and then another area is on-call schedule. So this is an actual chart that I made for a health center. If you look across the bottom, it's by date and hour. and the hours have been kind of thrown in there just to label them a little bit. And then if you look at the y-axis for number of providers, it goes from 0 to 20. And this practice, you can see the variation by hour, with Wednesday at a high of 18 providers, and the high on other days, such as Friday afternoon, is 9 providers, or Thursday morning at 8. And then you'll see sometimes there's only 1 provider there. And I think the important thing to get out of this is that this is an overlay to the rooms being the same the entire week in terms of availability, and the support staff coverage is the same every day of the week. So you can see it could be actually pretty quiet on Fridays, but when you talk to the support staff in this practice, they are just overwhelmed and think that it's just always crazy busy because of that Wednesday afternoon that they just really have a hard time gearing up for and then recovering from. This particular practice was fairly large and had a large residency program, and they brought all the residents in on Wednesdays, which made both space and staffing in short supply and presented a huge problem in terms of stress on the entire system. So it's important to match your assets. This is a simpler way to do it, but just making sure you know who's on, how many support staff are on, and how many rooms are available Monday through Friday, and try to accommodate your schedule so that either you're moving support staff around so that there are more on some days and fewer on others. But that can be difficult if the rooms are always the same that are available. So usually it means changing provider schedules, which can be uncomfortable because providers don't often like to move their schedules around from what they already have, but it can make a big difference in terms of providing adequate support and space. So I'm not really going to go through that. We're running out of time, and I just wanted to get to planning for vacancies. The other area to look is the age of your providers. Are you looking at who's planning to retire? And remember, for providers, 65 is not kind of the magic number. A lot of providers retire before that, and a lot retire after that. So it's really having those conversations with providers to get an idea in terms of retirement. But it is important to understand their age, have a pretty good idea of their general physical health, and talk to them about their future plans and aspirations. Some people may want to just cut hours down and not retire. The other thing besides retirement is looking at other changes in FTEs, if someone's planning on family, or again, someone's slowing down, approaching retirement. So this table is just kind of a way of trying to pull these things out into more of a metric to get an idea about the provider age range, whether you've discussed retirement, what their plans are, whether there are other major leave plans, sabbaticals, etc., and then what the expected changes would be in FTE so you can plan enough in advance to fill that time. So that's the end of the formal presentation. Mariah, were there any questions that came up?
Thanks, Patty. I haven't seen any questions come in just yet, and we do have a minute. So if anybody has any questions burning at the tip of their fingers right now, feel free to pop those in. But otherwise, I think we'll start wrapping up. So this is our webinar week. We'll look forward to having you all back with us next week for our discussion group session, where we can break this down a little bit further with a little bit of group conversation. Thank you again, Patty, for joining us today, and thank you everybody who's here on the line. I hope you all have a great rest of your day, and we'll talk to you soon.
Great. Thanks so much. Bye-bye.
Bye.